Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Welcome to the Digital Healthcare Experience. I'm Naomi Schwimmer, and today we have something a little different for you. Our discussion today will be more structured like a panel discussion because we have three great guest speakers here to talk about their research on the topic of implicit bias in digital health technologies such as AI. So I'm going to start off with some introductions of our speakers and then just hand the floor over to them. So first I'm going to start with our moderator, Huben-Kearney, a risk management and patient safety consultant who has published numerous works with ASHRM, the American Society of Healthcare Risk Management, the American Hospital Association, and the American Health Law Association on the topics of risk management and patient safety. Additionally, Anne speaks on the state, regional, national, and international levels and is a member of numerous patient safety and risk management organizations and associations. And Anne was named Risk Professional of the Year in 2019. She also serves on the ASHRM faculty for the Patient Safety Certificate Program and was elected to the ASHRM board for 2020 through 2023. Our next speaker is Doris Fischer-Sanchez, Senior VP of Clinical Risk at Marsh, the world's leading risk advisor, where she provides clinical risk services for Marsh's senior living and LTC industry in the US and Canada practice, and provides consultation and develops thought leadership, training, and other resources to clients regarding organizational and clinical risk to promote risk management solutions and best practices. With a doctorate in nursing practice, she maintains dual board certification in psychiatric and family nurse practice, and Doris is a fellow at ASHRM. And we have Ben Wilburn, a dedicated advocate for diversity, equity, and inclusion, currently serving as the DEI lead at Bottle Rocket Studios. With extensive experience in the field, Ben specializes in developing and implementing strategies, training programs, and culture-based initiatives. Prior to joining Bottle Rocket, Ben served as the Senior Inclusion and Diversity Specialist at the Institute for Diversity and Health Equity at the American Hospital Association. With over a decade of experience in training on healthcare topics related to transgender patients, Ben has expertise and a commitment to fostering inclusive environments. So thank you all for being here. Can't wait to hear what you have to say on this topic. And now on to our moderator, Anne Huben-Kearney.
Naomi, thank you very much. And thank you all for being here. Years ago, when Doris, Ben, and actually our fellow colleague, Maura Wertheimer, who's not with us, started on our journey of identifying implicit bias in healthcare, we never realized how the landscape about digital health, and particularly artificial intelligence, would change. We're not experts in the field by any means, but we have become more and more informed about how implicit, which is unconscious bias, is impacting what we see as outputs for our artificial intelligence. There are so many unknowns, and it's such a rapidly evolving topic and utilization that we have to continue to learn about it. And our goal here today is to show how our understanding of implicit bias has helped identify those opportunities to recognize and address bias, and then obviously healthcare. There's some good, which we'll go over, but also some risks that we'll identify. So let me just set up what we're talking about. Artificial bias is basically an anomaly or a variance in the output of machine learning algorithms. And we know AI, artificial intelligence, uses that. But it's due to prejudiced or biased assumptions when the algorithms are created, due in many factors, or many in the large part, to the sampling bias in patterns of health discrimination, that they're entrenched in the data sets. But sampling bias basically means that certain populations may be over or underrepresented. There's historical algorithms that have inherent biases that we're learning about. For example, kidney functions in African American patients. We know that the algorithms cannot correct for those biases because of the feedback loops that are introduced to learning continuously over time. Now, there's a couple of issues. One is both that I mentioned, the sampling bias. The other is the human choices that are being made during the design and development of the algorithms. It's data in, data out. And I'll put it bluntly, bias in, bias out. And also in the deployment of these systems, how the algorithms are being used and if they're being used appropriately. So we see many types of bias related to digital health. And I'm just going to talk a little bit about digital health, meaning particularly artificial intelligence, because that's really the elephant in the room. And that we know that there are health discrimination in the data sets, and that algorithms that are trained on those biased data sets don't change, they just amplify the biases. And we'll give you some examples of that. There's, again, the human choices, what are the sources of data? Doris is going to talk a little bit about, the rule-based versus generative AI and how that is a risk for artificial intelligence in healthcare because of where the sources of data are coming in. And obviously, what information that is continually being generated and analyzed by artificial intelligence. So every day we learn something new about digital health and artificial intelligence. There's so many discussions regarding how and if it's going to be regulated. And I think those are valid questions, how and if, beyond our scope of this particular presentation. But I think we want to start out with the benefits of artificial intelligence before we get into the risks. Before I go from there, any thoughts about some of those benefits? Ben, you have some thoughts?
I think when we're looking at benefits, very high level, we're thinking about operational things like workflow, equipment, and supply chain, things that we see even within human resources. Doris, any thoughts about things that are more clinical?
Yeah, I think when we look at clinical, we can look at the benefits of technology and predictive analytics, where we've been using them probably for a few years now. For example, insulin prediction, blood sugars, designer medications, all predicated off of the use of important technology. However, when we get into some of the drawbacks, I think that's where we'll see we have some work to do.
Along that line, I think it'll make a little bit more sense if we give you some examples. And then again, this is what we've done in our prior papers. Naomi had mentioned, but we three plus more have written 2 of the 3 series with the American Hospital Association and the American Society for Healthcare Risk Management on implicit bias in healthcare. Digital, as you mentioned, Naomi, is our last paper coming up. But one thing that we treasure and we value in our publications is the scenarios. We take that very seriously. It's people with whom we've talked, or perhaps it's something pulled from popular culture. So we want to go through some examples, some scenarios to sort of illustrate our point. And I'm going to start with dermatology. Dermatology lends itself to the software and the imaging and help with education and diagnosis. It's one of those that's probably benefiting greatly from artificial intelligence. However, the screening tools that are being used for education and diagnosis are historically based on non-Hispanic white males. So that those that the African-American people of culture, they may be 3 times more likely to be diagnosed with melanoma at a late stage because the images are not of African Americans or people of color. They are white, non-Hispanic, and they're not representative of the total sample of those seeking preventive or screening health or diagnosis. I'm looking at a resource that I checked, and that for medical schools who are teaching dermatology, they found that with all their images, only 15% were skin of color. And that's basically related to the sampling bias that we talked about, an underrepresentation. So I think that's one very clear example of artificial intelligence based on the data being put into the system. Doris, I'm going to turf it to you.
Thanks, Anne. I think behavioral health is a very prevalent area where artificial intelligence tools can be utilized and are really being developed. One case in popular media right now, though, illustrates the differences between artificial intelligence that's developed as a rule-based platform versus majority of programming that's developed as generative AI. And there is a company that worked with Washington University to develop a behavioral chatbot called Tessa. And this was endorsed by the National Eating Disorder Association. They, in turn, and they were rule-based, so there's no internet accessibility. It's a platform that's developed to understand questioning and such with scripted driven answers. And it's very specific in this case to eating disorders. And when aligning with a company that was generative AI in their model, it changed the way in which Tessa began to respond to folks that were trying to access help and information, which caused the National Eating Disorder Association to cut ties with that particular platform. And so at the end of the day, when we're looking at something that was meant to be helpful, that was scriptive and predictive for the professionals that were behind the scenes, we now also know that in terms of biases and insertions and the potential for hallucinations with respect to AI and the responses that it gives on the generative side, it can also potentially, if this at the end of the day is what they find out happened, also alter a different type of AI that's been created. So what do I mean by all of this? What I mean by all of this is that we have to be informed consumers when we're looking at what it is that we're choosing to utilize on behalf of our own potential workflow initiatives or clinical impact and decision-making with respect to the patients and the folks that we serve.
I'm going to get more into that, and I think I'm glad you brought up that particular example, because we're finding even with ChatGPT, and we'll talk about transparency later, but there's an emergent acknowledgement of discrimination related to the patient names. So when the patient is entering into that portal, for example, asking a question, they're finding that the information and the language is being filtered related to that assumed ethnic or racial identification. So it may not always be accurate or appropriate for that particular patient. But we'll talk about the risks and what needs to be done to try to prevent that from happening. Ben, you have anything to add?
One thing that just comes to mind as we're having this conversation and talking about kind of the good, the bad, the ugly, if you will, I wanted to touch on something about empathy that we keep seeing bubble up. And that is this idea that I assume, me personally, me as in Ben, that the interactions that we might be having with a physician, that we might have with a chat box, I would think that it would be very obvious that the physician, a human person replying, would be the empathetic, warm, fuzzy approach that, we all know and love. But what we've actually seen as of late is that there is some slight preference toward the chat box being more empathetic in its approach. And, there's this really interesting, very small study that we can look back on. It was about 195 people who were essentially evaluating these responses. And the authors entered these questions into a chat box, and they had a group of healthcare professionals kind of compare the answers. Well, what we actually saw is that people preferred the chat box responses and ranked them as more empathetic. And so it really does kind of mess with you a little bit. I think as a person, right, when you hear that, because your immediate reaction is that you might be able to identify that yourself, you might be able to base it on a feeling. And I assume a lot of people who were taking part in that research probably thought, oh yeah, this is the chat box, or oh no, this is the physician. And in reality ended up having that piece preferred. So I say that to say, I think we assume that the human touch will come through more than maybe it actually does. And that's something to be mindful of.
Excellent. Excellent. I think in all these examples, you can hear about the risks that are inherent or even the benefits, if you will, related to the empathetic response. But I think there's some other risks. And Doris, I'm going to ask you to talk about, patient and provider consent, because I think that's a major, major focus.
Yeah, so what we've come to understand is that with all new technologies, I like to call them the shiny danglies, we gravitate, and we don't necessarily always understand what the implications of that will be. And what I mean by that in terms of AI is, first of all, the data that's generated, right? And we're talking a lot about bias and what feeds a program or an application, and how does that get translated then into the outputs that come as a result of? Well, it starts with, and you mentioned it already, Anne, the data that's coming in. And so with that, we've always been familiar with coming into a practice setting or a hospital setting and signing consent, right? Well, with AI-driven potential clinical decision-making tools, predictive analytics, et cetera, I think as healthcare organizations and risk managers in particular, as we're looking at what the new emerging risks are, what is the level of consent that we've provided for the patient or the consumer, we as healthcare consumers, in terms of what's going to be utilized in addition to whom I think I'm seeing to impact my clinical treatment journey, as well as what kind of applications, algorithms, et cetera, are going to be utilized on me as well. And where's my data going? And who does my data belong to? And I don't think we're kind of anywhere there. I mean, it's starting to emerge. We look at, for example, this March most recently, and we mentioned this already as well. When we started this journey 4 years ago, this didn't exist, right? But there's now an AMA position on augmented intelligence and in the clinical world. And you also mentioned or asked me to comment on, providers in general. We also have to realize that today's world, physicians and other practitioners are being hired by organizations. They sign a contract for employment, and many times now they're also agreeing that there's going to be a decision-making tool that's going to augment their employment and their workflow. And so we say that we want clinicians to understand and to be, open with us about what they're utilizing, but do they even know as clinicians what's being utilized in their everyday practice? And so it's a whole new world, not right or wrong, just a whole new world. And are they responsible, or should there be a responsibility taken to help them understand what the tools are that are going to be used in their clinical decision making, and if there's any biases that have come forward or are inherent, or what was the research that was utilized to make those decisions in the first place?
Wow, excellent, excellent. And along that same line, I'm thinking about, as you're saying this, is the whole transparency issue. I think you've raised up a lot of those, hidden behind the scenes, in the background type things. As you said, who's aware of that AI is being used? Your example, Ben, about the empathy with the chat bot and the, chat GPT. Perfect. Who's answering my question? And is it valid? And is it taking into effect, my ethnicity, my name, my, gender, and whatever else might be, race, etc. Is it valid? Is it appropriate for me with those? And can I trace it? Is there a way of knowing who is responding and how is that documented in the medical record? And your point, Doris, about the bias that is inherent in a lot of what we're seeing, and some of it absolutely unknown to us. That's the concern. What is it, and how do we know about it? There was actually a discussion, a case example, for example, I need to follow up more on it, but AI picked up when a patient was using a mouse to respond, and there was a tremor. Now, was the tremor going to be now diagnosed? A possible diagnosis AI is going to come up with: patient has Parkinson's. Does the patient know? How is that information being shared? Exactly your point, Doris. Is it going to go to the health or life insurer before the patient even knows that that is a possible, diagnosis? So I think there is so much more about tracing and transparency And how does that get communicated to both the providers and the consumer? You've got something to add, Doris.
Well, I'm thinking about what Ben said about empathy and the addition of AI preferences and such, but I'm thinking about a new addition to the ambulatory world, and that is AI-assisted transcription. And so I wonder if, for example, say you had a person who happened to be, let's say, transgender, for example, and maybe they were either along the journey or they've completed their transition. And does the AI transcription understand where they are, and do they address them appropriately, and how is that learned, and who makes those decisions, and what's the EHR tool that we're utilizing, and who's doing that programming, and is it following a track across the system? I think there's we're being we're maybe the live beta testing, but again, I wonder what happens when those corrections are. Is there a log? We've been introduced through the EHR. If there's a correction to be made or something to be done, that we have to archive it and track our audit trails and such. I'm not so sure that exists in AI. I think it maybe autocorrects or does whatever, but how do we know that?
And I just got to add that autocorrects or does whatsoever, I think you mentioned it already, is the hallucinations. We don't know the disinformation or the false information that's being created, because AI, particularly the generative AI, that's taking sources of data from everywhere. And they're, in microseconds, how quickly they can absorb all that. But then they're creating their own responses or creating their own references or making up their own research. So your example with the dietary or the eating disorder, people were acting on incorrect information based on what they put in their query and the response they got. But how much of it was a hallucination by AI? And then those biases that are inherent with that, because they're reading blogs or they're reading something from the internet and not validating that this is biased information. They're just getting the information, the data.
Or realizing maybe potentially at the time when the person was attempting to utilize a particular chatbot, that they were in a place where they could accept what was before them and understand that something didn't sound or feel right about it. But let's say that wasn't the place you were in. And so Ben has mentioned many times the ethics behind these algorithms and these programs and such. And so I know you're much more articulate with it than I am, Ben, but just some of that insertion, if you would, bring us up to speed here.
Yeah, and I think I'm listening to you two talk and I'm thinking to myself, boy, what a wild place that we are in history. It's a tremendous amount of change happening socially, culturally. And as I'm thinking about ethics, I'm thinking ebbing and flowing. And I think it's important to acknowledge that there are a lot of opinions about this. And there are a lot of opinions about implicit bias in general. And the opinions about what it means to be ethical are also changing, it seems like, on a nearly hourly basis. But even without digital health, I think that's a part of the association. But part of what I appreciate about the conversations that we have together, the pieces of these papers that come together, is that we're operating from a place of knowledge being empowering. We think about these things with an open mind, and we're aware that, kind of like I said earlier, we're still humans, and we're still humans working alongside other humans. And so when I'm thinking about ethics, my first thought is risks. And after everything we've laid out here, I have to ask the both of you, Anne and Doris, what can we do to reduce the risk of these biases that we see?
Well, I'm going to take a first step at it, Doris.
Yeah.
I think that there has to be an organizational data strategy. You need to know who's using what, in what circumstances, and how they're utilizing it. that goes along with the technology infrastructure. That the AI companies with whom you have contracts acknowledge that there are biases and there's a risk of bias, and that they're going to continue to acknowledge that they exist, but also to test for them and to address the biases and not just let it be business. And this is how it goes, business as usual. It's a risk we take. I also think when we're talking about AI, I think there has to be committees that look at the potential use and the actual use and the risks associated with that. And it has to include not just IT, but the actual users as providers, the clinicians. I would love to see a patient on it from what you're talking about, both Ben and Doris. I hadn't thought about that before, but what better opportunity than to include patient in the committee so that they are aware of that potential bias and their consciousness is raised. I also want to talk a little bit about, before I go on as I'm thinking about it, is employee engagement and education. Your point, well taken, Ben, that we need to be aware of this. It's raising our consciousness, but we need to continue to build our understanding of AI as we would any other type of technology that we're using. When EHRs first came into existence, we had to learn about that. But I think we need to do, as we do that technology and that education, not necessarily to be afraid of it, but to make sure that we keep as top of mind both patient equality, equity, and safety.
Yeah.
Doris, you got anything else?
I think in addition to that, Anne, I think we need to have that responsible use of AI within an organization. We need to really pay attention to the consenting process. I think we need to, as you already kind of mentioned, and emphasis on Ben, partner and contract with responsible, ethical vendors who not only create an inclusive design, but some with foreseeability, not so much about hallucinations, and to create an AI program and application review cycle within the organization. And then who knew, really to understand whether you're dealing with maybe a homegrown rule-based AI program that you can correct and you can modify and you can so on, versus that generative AI program where we really don't know, and even the creators don't know what happens next. And then I think finally I'll add, I mentioned the AMA and their position. I think we also need to know each of our individual specialties position on the utilization of AI within our own professions. So for nursing ANA and for health information management folks, AHIMA and their position. And then, even with our own government, Health and Human Services, we know we have the OIG, but not until 2021 did the Chief Artificial Intelligence Officer position become available. And did we know that even to today, it's a person named Greg Singleton, and, is that whom it'll be in the future going forward? But I think as responsible consumers, users, and benefactors of this particular next generation of whatever, I think we have to educate ourselves.
Well said. Ben, any other thoughts?
Well, I mean, brilliant as always. But when I think about the work I do is so radically different, I think, than a lot of the other pieces in healthcare.
True.
I may not be a physician, right? But I'm a consumer. We are all healthcare consumers in some form or fashion. And we don't know what we don't know. And that's not something to be ashamed of. But as is true in most situations, we need to learn about it, and we need to be critical thinkers, and we need to ask tough questions. We need to have the space to ask the tough questions about AI, about digital healthcare. And then we can have these more informed conversations like we're having today, where we're in real time essentially learning together about these potential biases and how they may impact us, and how they may impact historically underrepresented, historically marginalized communities. And to also realize that as soon as this is leaving our mouths, we probably will have an update, minutes later. And so that's really what I will think about as we start closing out.
I also
Well-
think again that in the past, in the dark ages, when we were kind of not always as transparent. If there was, let's say, a resident that did a read on an x-ray first and then the attending came behind. Well, now we need to be transparent in terms of, and there are organizations that are doing this, but that this was AI read, resident affirmed, and attending validated, or however we want to say it. And in the world of pathology and in the world of surgical slides and, whatever we're doing. I mean, I think the transparency, the realities for me as a consumer, a patient, as well as a healthcare professional and a risk manager on top of all of that, not knowing what all the new risks are. And a final point too, when we've talked about this in the past, is litigation and what will come. And we know
Yeah, I
that
was
all
thinking
runs behind, but who will plaintiffs' attorneys be attempting to, hold to task? I don't think we necessarily know.
And that allegation of discrimination based on the output from an algorithm, based on sampling bias, who's responsible? I think that's a really, it's I think it's one of those things like watch this space.
Yeah.
There's more to come. We're continuing to learn. Our paper, will reflect what we know at this point. But I think you're right. There is so much more to come, and it's exciting. It's a little bit frightening. I like, we don't know what we don't know. But I think we have a responsibility to learn as much as possible about it and to use this technology appropriately and safely, but keeping, again, patient equity, patient equality, patient safety at the forefront. Naomi, we're going to turn it back to you.
All right. Well, thank you so much. This was a very interesting conversation. And speaking of more to come, we will have a part 2 to this conversation when we have all of you back in the fall for a panel discussion. So for our listeners out there who enjoyed this conversation and want to hear more and want to hear the updates, we plan to schedule this live webinar in the fall closer to the National ASHRM Conference. And by then, as I understand, your peer-reviewed article will be published and you'll have more updates. And again, this is an ongoing conversation. So, we will continue to foster that here. That's actually why we created this platform, to facilitate peer-to-peer conversations just like this. So, really appreciate you all being on and all the insights that you shared today.
Thank you.
And to our listeners, if you enjoyed today's conversation, please like, share, and subscribe. Help us grow the show. We really appreciate it. And if you would like to learn more about the digital healthcare experience or Taylor Healthcare, please visit taylor.com/digital-healthcare. And thank you again. To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer. Podcast music by Nicholas Bach.